So Jason Porter directs the lung cancer research at the West Clinic in Memphis. He does a wonderful job, lots of energy, and is a shrewd clinical trial enroller and leader in the field. Thank you, Jason.
Thank you so much for having me. I'm excited to be here. It's always fun to listen to Dr. Johnson talk. Always fun. Even when I was a fellow, I've been watching you. You didn't know it, but I was watching and I was listening. So happy to be here, happy to see all of you. Thank you to the organizers for allowing me to participate. And we will talk about metastatic non-small cell lung cancer, some of the updates recently. We know there have been some changes. These are my disclosures. And we start with the question. It's a 77-year-old male, came in for emergency evaluation with worsening dyspnea and cough, weight loss of 11 pounds over a month, CT scan showing a 9-centimeter left periohilar mass. With direct nodal invasion, he undergoes a bronchoscopy with the biopsy, and his confirmed histology is poorly differentiated squamous cell carcinoma. PD-L1 is 80% with no other oncogene drivers detected. His comorbidities are COPD. He's on 2 liters of oxygen continuously, coronary artery disease. He's had a PCI and has ischemic cardiomyopathy with the EDF of 40%. PET scan does not show any metastatic disease. And one of the following therapies is indicated in his locally advanced, non-metastatic, non-small cell lung cancer. So I don't think that we have like a clicker or anything, so we'll just go through that. That was just a question for you to think about. There's not really one answer for some of my questions that I've included, but just for our own sake, we could think about those things. So we know that non-small cell lung cancer is the second most commonly diagnosed cancer in both men and women, but it's still claiming more lives than than all 3, colorectal, breast, and prostate cancer combined every year. And somebody asked me, are you going to talk about screening? I'm going to always talk about screening. I'm going to always talk about screening. And these same slides, actually, I'm just presenting again because I think that the screening is, underwhelmingly undertaken or not poorly uptake. We're having poor uptake. And so here we see 5-year survival rates for prostate and breast cancer where there is screening is widely accepted and everybody's doing it. And it's not that we're not accepting lung cancer screening, by the way. The people in this room, again, preaching to the choir, we know that we believe in lung cancer screening, but it's not available to everybody, and everybody with lungs can get lung cancer. So I'm going to keep talking about a risk stratified access to lung cancer screening, just like we do colonoscopy. So if your colonoscopy is positive for a polyp, you come back sooner. If your CT scan of your chest at age 40 is positive for a nodule, then you come back sooner. If you don't have anything on the CT and you are never a smoker, then you come back maybe in 10 years with a repeat CT or just 5 years with a repeat CT. It's the least invasive of the screenings that we're doing. There's no boob squeezing. There's no scope into your rectum to look in your colon. It's just a low-dose CT with a low dose of radiation. And I think that it's probably the easiest of all the screenings to do. And while this cancer is killing the most patients, we should be doing it. And we're finding cancers in earlier stages of disease. When we look here, it's looking strange. Sorry, I don't know what happened there. But anyway, stage 4 curve is gone off the graph here where there's some kind of technical glitch there. But the higher the stage of diagnosis, the worse those patients are going to do. And we know that. And the lung cancer screening trials have shown us that if we do screen patients appropriately, over 60% of the patients in that red square are stage 1A or 1B. So that's where we should be finding those patients. That's the curve that we want to be on when we are diagnosing our lung cancers, whether a smoker or not, because we know everybody at risk or everybody with lungs at risk for lung cancer. So this is my outline. We'll look at immune checkpoint monotherapies, those already approved, immune checkpoint combination therapies, the IO chemo combinations, and then just briefly a couple of second-line things. So these are the monotherapies and immune checkpoint inhibitors. So pembrolizumab is technically approved for PD-L1 greater than or equal to 1%. And we have a long follow-up with that trial, and we see 5-year overall survival by PD-L1 status that are greater than or equal to 50%. We'll focus on here since this is monotherapy, and we know that less than 49 or less than 50% will usually add in chemotherapy. So 21.9% of those patients still alive with a hazard ratio of 0.68 at 5 years. The objective response rate nearly 41% versus 25.4% with chemo. Atezolizumab, same thing, PD-L1 high patients, median overall survival 20.2 months versus 13.1 months with chemotherapy, and their response rate of 38% versus 29% with chemo. And lastly, On the right, we have cemiplimab, which is the most recently approved of those by Empower Lung 1 trial, and we see a PD-L1 greater than 50%, median overall survival 26.1 months versus 13.3 months, with an objective response rate of 46.5%, which is really cool. There's a CR rate of 8.1% in that trial, but we also know that there was some advanced stage and not metastatic, so stage 3B and 3C included in the Empower Lung 1 trial. So that may be one of the reasons that we see some of those CRs. So for the IO monotherapies, we know that they're effective and that they're safe, and we're using them in advanced metastatic non-small cell lung cancer. The data with Pembro is more mature, but it's not to say that the data with the other two agents aren't coming along nicely. And though PD-L1 greater than 1%, greater than or equal to 1% is an indication for Pembro, like we just mentioned, if your PD-L1 is less than 50%, most of us are going to give chemotherapy in that setting. So we go on to a different question here. 71-year-old male with a medical history significant for 54 packed years of smoking is found to have a right upper lobe mass measuring 4.7 centimeters. A right hilar adenopathy is present as well. Biopsy is performed and he's diagnosed with the large cell neuroendocrine carcinoma. PET CT confirms a mass and hilar nodes that have an SUV of 11. And there is a left adrenal mass as well. So this is a little turn here because this is technically going to be oligometastatic disease. And just in the interest of time, I'll tell you that's what that is. And so what do we do with oligometastatic disease now? Before, chemoradiation and then maybe some local therapy for the metastatic disease, but we got these great neoadjuvant trials that Dr. Johnson just showed us. So is it appropriate to take your patient who has oligometastatic disease now and give them neoadjuvant nivo and chemo and then go on to do a more curative intent maneuver like a surgical resection with an adrenalectomy for a patient who's got adrenal nodule or an ablation or some other SBRT for the adrenal gland? That's the point of this question, and since we're not responding, I'll just tell you that's what that was. So here, we'll look at Checkmate 227. This was nivolumab plus ipilimumab versus chemotherapy for patients with metastatic or locally advanced non-small cell lung cancer, treatment naive with no ALK or EGFR alterations. It's actually kind of hard to see over here. With no ALK or EGFR alterations, PD-L1 expression greater than or equal to 1%. In the top portion, you can see nivo plus ipi versus chemo versus nivo. At the bottom, nivo plus ipi versus chemo or nivo plus chemo. The primary endpoints were PFS in the in high TMB patient population or overall survival for PD-L1 positive patients. We have 5-year overall survival with the nivo ipi now. PD-L1 greater than or equal to 1%, we see 24% overall survival at 5 years. So that's almost 1 in 4 of the patients that's still alive at 5 years with this regimen. Again, this is where PD-L1 was positive. And we look at PFS and duration of response there in PD-L1 positive patients. 12 versus, I think that's 2% on the PFS. And on the duration of response, we have, I'm actually just going to step out here, okay? Because I don't have glasses, 28% versus 3%. So a little bit untraditional, but there we go. And for the 5-year overall survival for PD-L1 less than 1%, so this is PD-L1 negative patients. And we know that the initial indication is for PD-L1 positive patients. But what when you can't give your patient platinum doublet chemotherapy? So here we see 19% versus 7% for PD-L1 negative patients, a median overall survival of 17%. Versus 12.2% with chemotherapy. For the PFS and the duration of response, also we see benefit, 10 versus 2% on the PFS for PD-L1 negative patients, and then 21 versus not applicable for the chemotherapy on the duration of response, again for PD-L1 negative patients, where this is often a consideration and it's necessary for various comorbidities, renal dysfunction, pre-existing peripheral neuropathy, and you don't want to give your patient platinum doublet chemotherapy and you still want to give them a combination, this is reasonable to consider. So 5-year overall response, 24% versus 14% with the PD-L1 positive and 19% versus 7% with PD-L1 negative. Median duration of response, 24.5 months versus 6.7 where PD-L1 is positive and 19.4 versus 4.8 where PD-L1 is negative. So again, a viable option for patients who are PD-L1 positive, but also for PD-L1 negative patients, you can consider Checkmate 227 regimen with nivo and ipi. So we look at the phase 3, Keynote 189, and then we'll look at 407. And there's a reason why we're looking at these two now. So Pembro plus carbo or cisplatin with pemetrexed. This is a 5-year efficacy analysis, a median follow-up of 64.6 months. At 5 years, we saw nearly 20%, so 1 in 5 of those patients still alive when treated with platinum doublet plus pembrolizumab. The hazard ratio of 0.6 versus placebo and chemotherapy. The median is 22 months versus 10.6 months. PFS for the intention to treat population at 5 years, 7.5% of those patients had not progressed with a hazard ratio of 0.5. And similar to what Dr. Johnson was showing us in her talks, on the PD-L1 level, as our PD-L1 levels go up from negative to 1 to 49 and greater than 50, we see stepwise increases in the 5-year overall survival as well as the improvement in hazard ratios. Same thing for the PFS. So Keynote 407, same thing, but for squamous cell carcinoma where we use nab-paclitaxel or paclitaxel, 5-year overall survival analysis here with a 56.9-month follow-up. And we see at 5 years, 18.4% of those patients are still alive. And it's really good. At the beginning of my talk, I had that screening slide, and there was one in there that showed, and we hear a lot about 5-year overall survival of about 6% in metastatic non-small cell lung cancer. So that's before our immune checkpoint inhibitors, and of course we're seeing better now. But like Dr. Johnson just said, 60% of your patients are still dead, and that's in the stage 3 population. So here in stage 4, 80% plus of your patients are still not surviving. So we haven't, made it to where we're trying to get, but we're getting better. The PFS in that patient population, 10.8 versus 3.5% at 5 years, and likewise stepwise increase in the PFS as well as the hazard ratio as we go up in the PD-L1 level. So conclusions for squamous cell and non-squamous, Keynote 407 and 189 at 5 years continue to show benefit for our patients who have advanced or metastatic non-small cell lung cancer. The 5-year overall survival for Keynote 407, 18.4% and 19.4% for non-squamous in the Keynote 189. So more recently, the Empower Lung 3 study has shown us cemiplimab plus chemotherapy in a fashion similar to what we saw in the Keynote trial. Cemiplimab every 3 weeks, 350 milligrams plus doublet chemotherapy for 4 cycles versus placebo plus investigator's choice of doublet chemotherapy. Patients here were eligible if they had advanced or metastatic non-small cell lung cancer. That was stage 3B, 3C, or stage 4. PD-L1 expression levels all accepted. No EGFR, ALK, or ROS1 alterations, obviously, and then treated clinically stable CNS metastases were allowed. The endpoints were primary overall survival and key secondary PFS and objective response rate. Those patients were treated until progressive disease or for 108 weeks. And we see a 12-month overall survival of 65.7% versus 56.1%, with a median at that time of 21.9 versus 13 months. The PFS, similar benefit, 8.2 months versus 5 months, median PFS. The subgroups all seem to favor the cemiplimab plus chemotherapy treated patients. We see here that the female patients don't seem to derive as much benefit, but we have to take caution knowing that there was a very, very small percentage of female patients in this particular clinical trial. Also down at the bottom, never smokers, and that's a widely accepted belief is that never smokers may not respond as well. But the truth is for those patients, unless they have an oncogene driver, we really don't have much better of a treatment to give them. So do we change our therapy? No, they still get the same standard of care. Another stepwise increase in the response rate as we look at PD-L1. So PD-L1 negative, 1 to 49 and 50 on the right side, and we can see more and more response as expected. This is a decrease in the tumor volume. As PD-L1 level goes up, we see greater decrease in the tumor volume. Now this is specifically cemiplimab plus chemotherapy, but initially I was very hesitant to give any of my patients monotherapy. And I know that's not the science, but after you have your dentist wife or a family of, or a friend of your family die after getting a monotherapy with the PD-L1 of 100%, it kind of gives you a little bad taste in your mouth. And so I was kind of hesitant to do monotherapy for a while, but I got a response curve that showed me PD-L1 levels, and a lot of times we talk about needing a rapid response. Well, look here, this one is against cemiplimab plus chemotherapy, but in the cemiplimab monotherapy, the Empower Lung 1 that we showed earlier, the decrease in the tumor volume for PD-L1 greater than or equal to 50% was just as fast, if not more rapid, than chemotherapy. So now I'm off that chemotherapy pendulum, and I've come back to a midline where I'm more willing to give a monotherapy when appropriate. But even here we see when cemiplimab was added to chemotherapy, the decrease in tumor volume was more rapid and much deeper than chemotherapy alone. So for Empower-Lung 3, it's effective FDA-approved first-line treatment, cemiplimab for PD-L1 high patients. And the addition of 4 cycles of platinum chemotherapy doublet to the cemiplimab has resulted in increased overall survival and progression-free survival for those patients. No new safety signals with the combination. And then the results now deem this Empower-Lung 3 regimen an effective first-line therapy for advanced or metastatic non-small cell lung cancer with no actionable oncogene alterations, and that's recently FDA approved. Poseidon is another trial where we look at immune checkpoint inhibitors, so now durvalumab plus tremelimumab with chemotherapy versus chemotherapy alone. Stage 4 non-small cell lung cancer with no EGFR ALK alterations, good performance status, treatment naive, for metastatic disease, and there were over 1,000 patients enrolled. They were randomized 1:1:1 to these 3 arms, the durva plus chemo, durva plus tremi plus chemo, or platinum-based chemotherapy. The endpoints were PFS and overall survival, and then we look at key secondary endpoints with the durva, tremi plus chemo of PFS, overall survival, and overall survival with high blood TMB. So we look at the overall survival rates from that clinical trial. We're out to 4 years of therapy, and this was recently presented at ESMO. And we see that at 4 years, I'm coming back out here so I can look at my numbers, y'all. 20.7% of those patients at 4 years still alive with durva plus tremi plus chemo versus chemotherapy with 8.3%. And on the right-hand side, we see durva plus chemotherapy versus chemotherapy, and there's even a benefit there, 16.3% versus 8.3%. All of the subgroups, again, favor durva plus tremi plus chemotherapy, and even on the durva plus chemotherapy survival or plot here, you can see that survival favors durva plus chemotherapy. When we look at histology, we know our squamous cell patients don't do as well, so we have 13.1 versus 5.5% with the squamous cell histology where durva plus tremi was given with the chemotherapy, and 25% versus 10% for the non-squamous patients. I don't include all of the patient subgroups that were presented here, but I did show you KRAS. And for patients who had KRAS mutations, look at them, 32.9, so nearly 33% of those patients still alive at 4 years versus 10.8 with the chemotherapy, and KRAS wild type 21.3 versus 10%. So the KRAS wild type patients look much more like the full population of patients with the overall survival of around 20 to 21%. But where KRAS is mutated, we actually see improvement. STK11 and KEAP1 mutations are the other two that I don't show here, but they're typically associated with a poor outcome. The interesting thing here is that where durva plus tremi was given with chemotherapy, we don't see improvement necessary for those patients, but we bring them back up to a KEAP1 or STK11 baseline. And so maybe we're bringing those patients who have harder to treat disease and worse histology to a baseline or a level playing field with the wild types. So conclusions, this is a result. We have 4 years of data now for Poseidon, and we see durva plus tremi plus chemo improving overall survival, even for those patients with STK11 and KEAP1 mutations, and then KRAS patients possibly even doing better. The non-squamous patients seeming to do better, but still it's a viable option for our squamous cell patients too. And these data do support tremi plus durva plus chemotherapy as a first-line option for patients with hard-to-treat disease, and this was just a few days ago FDA approved as well as a combination for use in those patients who have metastatic non-small cell lung cancer. So it's really exciting. I was on Twitter and I saw one of our colleagues, Jack West, make a comment about another treatment option in this setting, and I said, yeah, that's exactly what it is, and we need more treatment options. But the good thing about this, I really love the data with the STK11 and the KEAP1s, and not that we didn't already kind of know that those patients can do okay, but to see it mapped out and so well explained in this clinical trial is really exciting. And so for those patients, this is what I'll be looking for in the future. So we have a 67-year-old female diagnosed with metastatic non-small cell lung cancer with metastases to bone and brain. She undergoes a biopsy and is found TTF1 positive, P40 negative disease consistent with moderately differentiated adenocarcinoma. PD-L1 is 80%, the TMB is 14. The tumor is positive for EGFR. all of the following are reasonable except what this is actually a pretty easy one, so we'll just keep moving. So I have 42 seconds, and all I'm going to tell you in the last few seconds is that DESTINY-Lungo-2 got us an approval for trastuzumab deruxtecan at 5.4 milligrams per kilogram for patients who have HER2 mutated non-small cell lung cancer, so as a second-line therapy after first-line therapy in those patients. So the testing is immensely important. Moving those patients on to the next line of therapy is very important. Screening is very important. So I'm going to keep saying that over and over and over again until we all get screened. And so somebody asked me today, what can we do in pharma to help? We need to lobby. I need a screen too. We breathe the same polluted air. And if everybody in this room starts saying, I want my lung cancer screening, even though you're not a smoker, because 20% of us are still going to get it. So 100 of us in here, 20 of us are going to get lung cancer even though we're not smoking. So should we test? Yes. Should we screen? Yes. Should we test and screen? So I'm going to keep saying that. I hope y'all let me come back again because I'm going to put that about my screening in the talk again. And I see Dr. Daniel getting up, but I did want to tell you about sotorasib and KRAS G12C mutated non-small cell lung cancer. No, it's okay. And that is approved in second line for patients who have KRAS G12C. That's actually since May 2021, so that's not new. But again, this is a time where if you haven't tested the patient, you can't get them on this trial, and you put them on docetaxel, and the response rate is not nearly as high. So you're doing an injustice again. So everybody needs to be screened. Everybody needs to be tested. And the craziest thing that I'm going to say right now is I have a special guest in the room who is going to kill me for pointing her out. But my sister wanted to come and hear me speak today, and so she's over there with her husband. She is my best friend, and I'm really happy to have her. Thank you for coming. So that's it.
Awesome. So, Jason, it is getting hard, and I spend most of my time with lung cancer, but it is getting hard to tell, particularly when we start to have multiple agents on the market and they're being compared to the old standard. Tell us real-world evidence, things like that. Do they influence you? How can we understand, like, if there are two agents in the same field, how do we make these decisions?
I think real-world data is invaluable. We definitely need to be looking at it, especially in places like where we have 3 monotherapies available for advanced high PD-L1 expressing non-small cell lung cancer. The real-world data is very important. The patient-related patient-reported outcomes are also very important because quality of life is a big deal. I look at the cemiplimab tolerability, and the patient-reported outcomes from that trial actually look really good. And so looking at real-world data and getting the patient's perspectives on their therapy is really important. I had a patient on a monotherapy that developed pruritus that was the worst, didn't sleep for about 6 weeks, and came to see me in clinic. And I was like, well, we're just going to keep treating, and told me, well, you can get the therapy today because I'm delirious. I haven't slept in weeks, and I don't want any more treatment. My quality of life is horrible. So not only real-world data, but the patient outcomes and how they kind of explain their experience is very important.
Thank you, Jason. Any questions? Thank you again. I appreciate it.
Thanks.
Thanks.